Today we are going to discuss the ever increasingly popular evaluation of clotting in a critically ill patient, the thromboelastography, or commonly refers to as TEG. TEG measures the viscoelastic property of blood during coagulation. It helps treat coagulopathy while minimizing the use of blood products. Now TEG has been very beneficial in evaluating and really helping and guide treatment and resuscitation effort in trauma and surgical care, and we are really finding an ever growing popularity in many areas of critical care, including management of ECMO, liver transplantation, postpartum hemorrhage, cardiac surgery, and many more. In this lesson we are going to talk about what is TEG, or how does it work, what are the different values, and how to interpret different tracing, and also what are the treatment options. As you know, thrombus formation is a 4-part process. The TEG machine analyzes each phases of the clotting process. The machine has a cup which oscillates, and there is a pin, a torsion pin submerged inside the cup. The pin is connected to the computer. Citrated blood is introduced in the cup, and the cup is heated to 37 degrees Celsius to stimulate the temperature of the body. So the machine is switched on, the cup starts to oscillate, but the pin remains motionless until the clotting begins. See, now the pin is not moving, only cup is moving. After 5 to 10 minutes, as coagulation occurs, the blood becomes thick and the pin adheres to the clot and begins to move with it. So now we can see both are moving. That means coagulation starts. The pin motion will be displayed graphically by the computer. The magnitude of the pin motion is directly proportional to the strength of the clot. The amplitude of the pin motion increases as a clot grows stronger, and amplitude decreases as fibrosis begins and the pins begins to slip. Now we are going to see how the graphics are displayed by the computer. This is a normal tracing, and we will see how it is formed. When the machine is switched on and the cup starts oscillating, first a straight line is formed. After 5 to 10 minutes, clotting begins. The pin starts moving and it's recorded here. As I told, the amplitude of the pin motion increases as the clot grows stronger, and amplitude decreases as fibrinolysis begins and the pin begins to slip. So this is the first parameter that is recorded. This is the R time, or the reaction time. So reaction time is the time from the start of the test to the first measurable clot is formed and is impacted by coagulation factors or the presence of anticoagulant like heparin. So what's the normal R time? Normal R time is 5 to 10 minutes. So if you get a prolonged R time, that means patient has have either deficiency of clotting factors or presence of anticoagulant like heparin. So how to treat this? Give fresh frozen plasma which contain all the clotting factors, or use drugs which reverse anticoagulant like protamine for heparin. So R time or reaction time is the time from the start of the test to the initial fibrin formation. So he is a 25-year-old female admitted with a road traffic accident, and now she is bleeding profusely. TEG is showing increased R time. Here we can consider fresh frozen plasma. So R time is the first parameter that is measured. So totally there are 5 main parameters. First is R time. Second one is the K time. So what's the K time? As I told, from here the clotting starts, and this clot should have a particular strength, and it is impacted by fibrinogen. So K time is the time elapsed until the clot reaches a fixed strength. Normally it takes 1 to 3 minutes to reach this strength. Elevation in K time represents a deficit fibrinogen and is treated with cryoprecipitate. So K time shows the strength of the clot. So a 40-year-old male admitted with bleeding manifestation, and the TEG is showing an increased K time. Here we can consider cryoprecipitate which contain fibrinogen. So once more, first one is R time. If it is prolonged, consider fresh frozen plasma or consider reversal of anticoagulants. And K time, if it is prolonged, we have to consider giving cryoprecipitate. And the third parameter is the alpha angle. It reflects the speed of the fibrin accumulation. Fibrin should accumulate within a particular speed. Normal speed is 53 to 72 degrees. A low value represents deficient fibrinogen and is treated with cryoprecipitate. So alpha angle reflects the speed of fibrin accumulation. He is a 72-year-old male on ECMO, developed bleeding manifestations. So TEG is showing a decreased angle. So here we can consider giving cryoprecipitate. So first is R time. If it is prolonged, we have to consider FFE or reversal of anticoagulants. Second is the K time. If it is prolonged, we have to consider giving cryoprecipitate. And third is the alpha angle. If it is low, consider giving again cryoprecipitate. Fourth parameter is the maximum amplitude or the MA. See here, this is R time. From here clotting starts. So MA or the maximum amplitude is the highest vertical amplitude of the TEG tracing. Normal range is 5 to 7 cm and is impacted by mainly platelets and also fibrin factor 2 and 3. A low level value represents a deficit platelet and is treated with platelet transfusion. And also consider something like a DDAVP, which increases the release of factor 8, acting much higher on the clotting cascade, leading ultimately to platelet activation. So the final value that I do want to talk about is the LY30, which is essentially the percentage of clot lysis 30 minutes after the maximum amplitude. So what does it mean, lysis after 30 minutes? This is the maximum amplitude or MA. The percentage decrease in amplitude at 30 minutes. This is the fibrinolytic phase. Normal range is 8%. A higher value indicates excess fibrinolysis and is treated with tranexamic acid or aminocaproic acid. So LY30 is, if it is high, you have to consider tranostat. So once more, R time is, if it is increased, you have to consider fresh frozen plasma or reversal of anticoagulant. K time, if it is prolonged, you have to consider cryoprecipitate. If you get a low angle, again cryo, and the MA is low, we have to consider giving platelets or DDAVP. The LY30 is high, you have to consider tranostat.